So I've been asked to talk about NHS funding, resource allocation and commissioning, which is the boring bit, I would say, of the NHS. And so I am going to overstep my brief at some point, but I want you to understand what this is all about. What we've got to do is we've got to improve care and patient outcomes for all that use the NHS in England at best value. And what's really important is when you start, you've got to show where you come from. So that's my NGR data for total hip and total knee replacement with survivorship at 10 years. So I'm quite proud of that. And so I hope that gives me the opportunity to walk the walk and as well as talk the talk. So if you go back to the founding of the NHS, Ivan Bevan was the gentleman who did that. They did some work before they started, and it suggested in 1942 that the total cost to start up the NHS would cost about 130 million. But the budget, when they came to it, was much more than that. It was 373 million. And if you put that in today's terms, that's 10.7 billion pounds. So that is a 12th of what we spend today. And what's really interesting is if you look at that, as soon as they'd set it up, the Treasury were worried about everything, all right, which has not changed from 1942 right through to the present day. Hospitals were over budget. The dentistry was over 3 times the cost they predicted. Ophthalmology was 5 times the costs. And in 1949, nurses were awarded a 30% pay rise, and more people were being employed than anticipated. And in 1 year, the NHS pay bill went up by 22%. And the Treasury were worried then regarding the affordability, and it still does. So this is the Department of Health Social Security bill in 2021. This is what we spend. And what I've added there is the extra money that was spent because of COVID in 2021 and 21, going forward 21, 22. So you can see there was a massive injection of COVID funding in 2021, still a third of that in 21, 22. And there is no doubt that that increased funding is going to reduce because of the affordability. But you can see since 2008-9 to where we are now, we've gone up from 118 billion to 159 billion. So we are investing a lot. So how do we stack up? All right, so this is the Commonwealth Fund, and it was set up by this lady in the top left-hand corner, Anna Harkness, in 1918. And this is in 2014, which is where we sit in terms of ranking across all the other countries you can see there. And you can see that in 2014, we were rated really as the country that on the whole gave effective, safe, coordinated care, patient-centered care. And overall, we were #1 in terms of that. If you then go forward and look at 2017, which is 3 years later, our overall ranking was still 1, but look at our healthcare outcomes where we've now moved to. We've gone from being ranked very highly in 2014 to #10 in 2017. So although overall ranking was still value for money, our healthcare outcomes were perceived, and I think rightly, as not being as good as other countries. And we know that the health services across the world are financed in different diverse ways, and we are still judged the best, safest, and most affordable, but not for outcomes. And it's something that I've really had to be in my bonnet we've got to do something about. And what's going to drive things going forward? Well, it's this. So I've put up here the world debt in 2010, that's 11 years ago. And world debt in the UK was 70% of GDP, and it was 1.5 trillion US dollars, all right? So if you fast track to where we are now, our public debt is now almost not far off $3 trillion, which is 103.7% of GDP. And there's been an annual debt change there of 7.8%. So we have an issue and we've got a problem. How are we going to continue to fund what we're doing? Why? Because of this. We're in a perfect storm. aging population. By 2030, 33% of the country will be at 60 years and 15.3 million over 65 by 2031. We're living longer, expected to remain active, although our lifespan has stalled currently. And we've got increasing BMI. By 2050, 60% of men and 50% of women will be obese. And if we look at patients we're admitting to hospital, more than 65% our patients admitted are 75 years of age or greater. And we are still, therefore, big players in the game. We're 33% of the surgical workforce, and we carry out somewhere about 25 to 26% of all surgical interventions if you lump trauma and orthopedics together. So people remember, some people remember, well, I certainly do, the Lansley reforms in 2012, which was based on the premise of introducing competition between hospitals and separating primary and secondary care. So primary care would be given a budget of about 60 to 70 billion pounds, and they would spend that within their local communities and in the acute trust to get care. And it was decided that some trusts could be foundation, where they'd have much more control over their finances, and other trusts like mine would be non-foundation trust, and you were monitored in a very different way. And for the non-foundation trust, it was very difficult to find capital, grow and invest. So this is the budget devolved to GPs and CCGs, although they kept some of the budget for themselves, such as high-cost drugs, specialised commission like the bone tumour service that I helped run at RNOH was one of those. And it was assumed that competition would improve productivity. There'd also be patient choice, and the independent sector here had a strong voice. What's happening now is commissioning is changing significantly. We're now moving away from competition between trusts to joined up working and collaboration. So that is where we're moving to. As people know, there are 7 regions that make up the NHS in England, and what I'm talking about is just the NHS in England. If you look in the Northwest, we've got 3 ICSs, and ICS is a grouping of hospitals, community providers, mental health providers, GPs, to look at a system level, integrated care system, to provide care for the totality of that population. In the Northeast, you've got 4 ICSs, and in the Midlands, you've got 11, London's got 5, East of England has 6, Southeast England has 6, and Southwest has 7. So it's all about population health, local councils, primary care, secondary care to community, all working together and collaborating as partners. So that gives you 42 ICSs in England. So if I just tell you on the top right there, I work in the ICS in London, of which there are 5, the North Central London ICS, and that includes hospitals like UCLH, Royal Free Hospital, Barnet and Chase Farm, Whittington, North Middlesex, Gosh, and the RNOH. And you can see it's a mixture of tertiary referral, complex and teaching hospitals and DGHs. So what they're saying is that I'm now an orthopedic surgeon in North Central London. Currently, the system that we're using this year is a block contract for each system. And there is one added to that. Because of the massive problem we've got regarding our waiting lists, they've added an addition to that, that if a system goes above 85% of its previous activity, it will be paid a PBR for each case, which gives the potential for the system to earn money and then hopefully reinvest some of that in its own systems, in those specialties. But also those patients can be performed and have their surgery in the independent sector. So here we are. So we all have professional responsibility, all of us on this call, to make sure that we provide the best and most cost-effective care. So outcome over cost is value. And what I've always tried to do is make sure that we are in the position where we are using every pound of taxpayers' money to the most efficient way we can and provide the best outcome. So you can see on the left here, there's the money, and on the right, I've got a bloke with his head buried in the sand. We can't do that anymore. We are all heading for a timing where we are going to have to extract best value, and we will be measuring this in a way that we weren't able before. And the reason I say that, and the reason I put this picture up is this is my mother-in-law who's in hospital, and that's my family around her. That is the person who doesn't have any voice. The youngsters, not a problem. My wife and I are still, I think, relatively young, but my mother-in-law had no voice. And it's up to us as clinicians to provide that voice for our patients. Because if we do things better, and we can do extra things with it, and for every £1 million that we can actually be much more effective in spending, then we can do an extra 200 joint replacements with that. Which brings me really to the long-term plan. And this is where I think I've got a big role to play going forward with the GIRF programme. And basically taxpayers' investment will be used to maximum effect. And that comes back also to the title of the talk and also our professionalism. Because what I would say to you on the call, orthopaedic surgeons, is how do you justify this sort of scenario where you're using an implant that costs £5,000, and yet if you use a cemented implant costing £650, all the evidence from the NJR shows in this patient who's over 65 that they will get the best result with a cemented implant. If you look at the high volume, the low volume, high complex cases, we've got to make some decisions to ensure we get the commissioning right about who should be doing this sort of surgery on the left. One of my patients that was referred with a absolutely smashed up tibial plateau, and we had to do a reconstruction using one of our massive endoprostheses, but surely we've got to decide where we do that and how we do it. And what about this around infection, around joint replacement? We think there's about 800 to 1,000. Again, expensive, complex, needs to be done to ensure best value, that these are done in places where you have all the team to do that sort of work. If you look at the National Joint Registry, since the GIRF programme started, we have seen a reduction year on year in revisions for hip and knee replacement, which has been great. Number of factors, the ASR, metal on metal, but overall, we've seen the low volume surgeons doing many less, and therefore we're seeing better outcomes. But if you look here at the NJR from 2019, there were 4,000 knees undergoing a single stage revision, and then a number going to 2-stage revisions, etc., and hips 6,000. So the question is, are we saying that everybody can have a go at that? And the answer is no. One of the things we also need to look at as part of what I've been asked to talk about is reorganising of our services to make sure that we get the best outcome for our patients. So this is United Lincolnshire, and you can see there it consists of 4 hospitals: Lincoln, top left, Louth, top right, Boston, bottom right, and Grantham at the base of all those arrows. And what they were doing when I went there was they were cancelling joint replacements, 900 in 1 year. Staff morale was poor, patients unhappy, long length of stay and average outcomes. So commissioning wasn't right, outcomes weren't right, and they asked us to do something different. But look at the distances by car from those hospitals to Grantham, which we made the cold elective site. So this is 2 years on from where we did. Now look at the top right, which is the outcome for hip replacement, knee replacements on the top right. And then look at what's happened since they started. They're coming back into the funnel plot. They've become an exemplar length of stay for day for hip and knee replacement, increased day cases, reduction in revision rates, litigation across the trust was improving, going to 5 joints a day through the same facility, increased productivity, staff morale improved, and before COVID came, they were going to do exactly the same in urology and gynecology. And no one, patients or staff, wanted to go back to the old way. So I said back then in 2013-14 that what we needed were hub and spoke models. And I'm glad to see that the Royal College of Surgeons is now saying exactly the same thing. And there's no doubt it is the way forward to ensure commissioning's correct, we get the value for money, and we spend our money in a proper way. So many of you may have seen me at a GIRF meeting, I don't know, but look at this slide. So when GIRF was started, it was all voluntary. And this is a trust in London, actually. And I've highlighted their outcomes in terms of revision rates. And you can see their outcomes were poor, long lengths of stay, high readmission rates and high revision rates. But despite me going there 3 times, management and clinicians did nothing with the data. And what you could say is, this is a huge consumption of resource with no benefit. So why should we spend taxpayers' money in commission when we see outcomes such as this? I've now addressed this problem because in London, we're delivering a program called the High Volume Low Complexity Work, and this is no longer voluntary, it's mandated. So I've been able to resolve this. And I think COVID now has given us an opportunity to really do things in a different way. In wave 1 of COVID, we got absolutely smashed, and we know that there are 5 million people on waiting list. There's 92,000 orthopedic patients waiting more than a year. And across every specialty, we've seen a huge rise. And the thing is, there's also this hidden referral group, because there was a massive reduction in patients referred during COVID-1 and COVID-2. So we've got a massive problem. And so what we've developed in London is the High Volume Low Complexity program, which I believe will provide us with the right professionalism, will provide an opportunity for commissioning in a real purposeful way, and will ensure maximising the funding of the NHS to produce best value. We've looked across 6 specialties on which orthopaedics is one, and we've focused across a system. So it's all going to be system working from now, and we've set the new benchmark as the top decile of the GIRF outcome. So average is no longer good enough, and we've standardised 29 pathways, of which 6 in orthopaedics. They are hip replacement, knee replacement, unicondylar, foot surgery, shoulder surgery, and ACL reconstruction. And we want to establish fast-track surgical hubs, and we've set the 30 principles of start, finish times, turnaround times to maximise outcome and benefit. So this is the first time that we have been able to set a standard and our systems and trusts to look at where they sit on that standard. And this, I'm sure, will become part of the business as usual when we talk about commissioning going forward. Are you addressing and are you hitting these standards? This is a pathway for total hip replacement. And what I'm concentrating on in the middle is the number of patients on the admitted pathway that we've got to deal with to get going. And these pathways have been signed off by the specialist societies and the colleges and also the BOA. We've also said what we should be doing in these lists, and we've tried to set them up so they can be teaching lists, 4 joints on a day. And we set the day rates of what we should be doing as day cases to actually maximise the day case rate. When we get that right, that means we'll free up inpatient beds to actually do the more complex work. And what we're going to need going forward is hub sites. So I'm in the process of trying to increase those around the country to ensure they're resilient, they're safe for patients, safe for staff, effective and efficient, and actually make a big difference to training. And in terms of commissioning, I think that's got to be the way forward, how we drive things. And what's going to allow us to really look at things is data. Something that all of you are going to have to get used to in a way that was not there when I started, but is there now. So this is average length of stay for primary hip replacement. This is in the southeast region, and those are the 6 systems of the 42 systems across the country. We want people to be at the green line, but just look at the variation out there. And then when you drill down to individual hospitals, how come Medway's got a length of stay of almost 5 days, where Hampshire hospitals are between 2 and 2.5 days? So what we need to do is learn from Hampshire and Maidstone and put into Medway, Southampton to drive change. Because if you get that right, then we're going to ensure that we free up beds to do more work through the existing facility, and therefore we'll be treating our patients. This data, I think, is going to be paramount in future commissioning. Look at the revision work. This is revision of primary hip replacement within 5 years. You can now see it across every single system in the country. We want people to be at the 0.5% level, but look at the variation across every system. And then when you drill down into hospitals within a system, you can see there is significant variation. So again, we're going to look at things in a different way. And when you look at day case procedures, it's exactly the same. You can see across the southeast region again, the 6 ICSs, and then you can drill down conversion of the day case rates to inpatient stays, and then you can look at things like cancellations on the day. Fracture neck and femur again, it's going to show us data we've never had before, which is going to impact on commissioning, on how we spend our money to get the best value. And lastly, look at this. This is theatres utilisation. This is 4 orthopaedic theatres, 48 sessions, average late start 38 minutes, intercase downtime 49 minutes, and touch time utilisation only 52%. Why would I go and continue to invest and commission this sort of work when we're wasting so much time and money? So what we've done in orthopedics, we're already setting the pace in revisions in terms of we're going live across England for revision knee centres by September. Elbows, shoulders, ankles, the society is already working on that so that we can commission those in a joined up way. And then behind that is a program called NSIP, which is the National Consultant Improvement Program, which takes unit level data like you can see there, and then you can drill down to individual surgeon level. This is not for publication. This is to aid annual appraisal and reaccreditation. So what we've got to do is we already know that we've got tough times coming. We've got to commission well, we've got to join up, we've got to work together, we've got to work across systems. It's got to be regionally led, system delivered, and we will enable it with good outcomes and best value. And it will be inspired by excellent clinical leadership. So what it means for all of you is, as we move forward into a new NHS with funding in a different way, you will work across systems. We all need to own the problem, no more silo working. We'll be working in teams, working in hub sites, and that will produce better outcomes, trauma and elective, allowing to use our precious pounds more efficiently and effectively. And it will be underpinned by data collection, both at system trust individual, and it will help an annual appraisal and revalidation. I see this as standardizing at the top decile. It'll improve training and it will improve outcomes. Thank you very much indeed.
Professor Briggs, it's Neil Kank here. Unfortunately, I can't get my video on. Thank you for putting it into perspective. Thank you for making it T&O relevant and, inspiring a new generation of leaders. I know that you've got another meeting to help the elective MSK recovery coming up, but you are coming back to us after that. And so to give you the chance to keep your well-being, we'll let you go for now, and we will ask you any questions afterwards if that's okay with yourself.
See you later. Cheers.
See you soon. Thank you.
Thank you, Professor Briggs.